The orthoPAC podcast, hosted by Sam Dyer, Chuck Dowell, and Miles Gilbreth. Welcome to the orthoPAC podcast, where we attempt to fill in the gaps between education, current events, and real-world practice. Welcome back, listeners. Today we have another panel discussion with Chuck and Miles, and we're talking about when can we return to sports after an injury?
I get more questions acutely from patients that are coming in that have just been injured, wanting to know what their timeline to recovery is. And I'll give them general basis, say if it's a fracture, 4 to 6 weeks of mobilization, and then progressive range of motion from there, or an ankle sprain, I kind of, run them through the recovery of what we can expect from that. But I really try and keep it very open and let them know that they need to follow up with a specialist to make sure that their return to activity is being monitored and guided in the most appropriate way.
I think that's a great point. And being in urgent care, I mean, all three of us, gosh knows how many distal radius fractures or ankle fractures, or why don't we talk about that a little bit? What can we tell folks? Let me do an example. Let's say we've got a pediatric skeletally mature buccal fracture. How long before they can get back to playing if they're in a cast, and how long before they're completely unrestricted out of a cast? Let's just say it's a simple little buccal fracture, non-displaced, but you want to protect it in a cast. What do you think about that, guys?
So it kind of varies by doctor. A lot of time for those buccal fractures, if they're not significantly displaced, we can seemingly get away with a cock-up wrist brace for those kids if they're compliant. And, the activity level return is, are you going to be an offensive lineman with a buccal fracture? Probably not. Are you going to do gymnastics with a buccal fracture? Probably not. And so there's such a varying degree on those.
Yeah.
And it really just depends on the kid.
I would agree, Miles. I think it depends on the sport too. We have a lot of soccer players and they come in and they have these buccal fractures, and we let them go back and play in a cast because it's a lower extremity sport. We know those fractures are inherently very stable. They can go back and play usually in a short arm cast, kind of depending on the location of the buckle. If it's bicortical, if the ulna's involved, maybe sometimes we'll have to put them in a long arm cast. Again, as Miles said, if it's an upper extremity sport, then they're probably not going to go back to doing those activities, but they can still potentially do some of the lower extremity conditioning. Buccal fractures are obviously unique because those are very stable fractures. I had an 8-year-old kid come in last week who had a buccal fracture, and he was 10 days status post the injury, and he had just shoveled snow for 2 days during our big snowstorm using that arm. And he came in with a completely, mildly angulated, but, stable buccal fracture that he was able to shovel snow with. So it just kind of shows you the stability of those fractures and our ability to maybe let them do a little bit of increased activities, especially for lower body training activities. So we let them play soccer in a cast. We let them do lower body exercises and kind of, training in a cast, and they usually do quite well.
Yeah, I think those are all great points. I wanted to throw in my 2 cents with the distal radius fractures. I agree completely. And part of that, what Chuck just described, how many times have you had somebody come in and say, I have a high pain tolerance and the sight of a needle makes them break out into a sweat, versus the kid with a fracture shoveling snow, or the person with an ankle fracture has been walking on it. So when somebody is demonstratively telling you they have a high pain tolerance, that equals low pain tolerance in my experience. Just FYI, that's a pearl I've learned over the years. But with distal radius fractures, if you're letting them return to sports in a cast, even if they're protected, I think there's a little bit of liability there. So you got to be careful, and they have to lay a lot of crepe. If it's a ped, I think you really want to make sure the parents, just say, hey, this is the situation. I think everything's great, but the stuff can happen. This fracture could angulate, and then our treatment may change, prolonged casting, it could even change to this. So it's up to you. If it's not like a competitive athlete, if it's the kid that's, bouncing on trampolines with something, that's a higher risk thing. So, if they're going to be cool and take it easy, then a cock-up splint. So it kind of becomes an issue of, can you trust them or can you not trust them as far as how you're immobilizing it? That's kind of how I think about that.
It's funny you mentioned trampolines. I had an anecdote came to mind. One of the private high schools close to my clinic, for their it might have even been seniors only, they went to a trampoline park for the day towards the end of the school year. And I think I had 4 or 5 kids from that high school. in my clinic that afternoon with injuries from the trampoline park. And these are skeletally mature 18-year-old kids. It was senior day trampoline park day in the clinic, and it was remarkable number of injuries that I saw.
Oh yeah, I think if you want to get busy, take your business cards to the trampoline park and leave them, laying around. How many times I can't tell you how many injuries I've seen from trampoline parks. It's just crazy. I think if I remember right from the American Academy of Pediatrics, trampolines are the number one cause of pediatric fractures, if I remember that correctly, or if not the number one cause, one of the number one causes.
I would like to say, building off of what you just said, it made me think of something which I think, talking to our younger colleagues, when I'm seeing somebody in clinic with an acute injury or fracture, and we're kind of having all these discussions, the mechanism of injury is always important to me. But I think in pediatric patients, kids want to play sports. Most kids are very motivated. They want to play sports, as you made a point at the beginning. Even if they've only been doing karate or their sport for 2 weeks, they're like, I love this. I want to get back and play. And so one of the questions I always ask them is, hey, if you had a game tonight, could you go play in that game? And I think in kids, if their answer is no, that always puts a red flag in my mind of this could be a more significant injury, because kids are resilient and they want to go back to activities. And almost always they're going to tell you yes if they feel like they can. And so that's one of the questions I think is a good question to ask, especially pediatric high school age population that come in with an injury, to kind of dive into the severity of the injury or their ability or their kind of pain control tolerance. If a kid is telling you, hey, I can't go play my sport because it hurts too much, I'm always worried that this could be more of a significant injury. And I tend to kind of progress things a lot slower in those situations. Just my personal kind of opinion, but
Chuck, I completely agree with that. I ask the exact same question to kids that are injured, that older kid, the high school level athlete, and they ask, when can I get back to playing? And I say the same thing. If you had a game right now, could you go out and play? And I definitely use that question to guide what their activity restrictions are.
Guys, I think those are great questions to ask. And let me kind of flip that around a little bit. And I'm sure you've seen this. I have. The parent that comes in that thinks their child is the next Michael Jordan or the next, Micah Parsons or whatever, and they're pushing. You've got to get back, and, you got to suck it up. I've got to live my life through you, the sixth grade championship or whatever. What do you do in that situation where you think maybe this is not a great idea? Maybe this child doesn't really want to play. And that happens. It's happened not infrequently. So in my experience, so what do you say about that? What do you guys think?
yeah, I think that's the same thing. I feel like when you're interviewing the patient and the child, and as Mild has said previously on one of the previous podcasts, I tend to walk in and talk to the patient, the child, as long as they're of speaking age, and kind of not look at the parents and try to ask the child and or the athlete questions directly, and try to get what their facial expressions are, what their kind of responses are. And if you could see that their responses, they maybe don't want to go back and participate in those sporting activities, I'll often just, take it out of their hands and say, hey, I think we should take time out of this. If you're getting that sense that maybe it's not some sport they want to return to, they were kind of pushed into that sport, or maybe they feel like they're doing too much. These year-round sport athletes that oftentimes get burnt out at times. I'll try to kind of take it out of their hands, not make them make that decision, and just say, hey, I think we need to really stay out of the sport for more an extended period of time to let this calm down.
Yeah, I think I get that situation a fair amount. I also get the situation of a highly motivated young athlete that it is truly internally motivated to get back to their sport. And I oftentimes have to have the conversation of, okay, if we get out of the sport now, if we protect this now, if we offload this now, we have a higher incidence of returning during this season at a high level. If we don't protect it now, if we don't immobilize it now, and we continue pushing through, it can get worse. We can not perform to the level that we want for the entire season. And just kind of breaking that down of, hey, we need to take this step back now in order to return, as opposed to pushing through it and letting it linger for the whole season.
That's an excellent point, Miles. And I agree with you. I think that depends on where they're at in the season too. I often ask, if they have a competition in 4 weeks and they're like, my goal is to get to that competition because we're traveling out of state. Like you said, take 2 weeks off now, allow this to completely heal. So you're 90% for that competition. If they have 2 weeks left in the season, then fine, they can return to those sports as long as you feel it's safe and the injury is not going to get, made worse by returning, but they're probably going to be at best 60 to 80% of what they normally would be. And they just have to understand that.
High on the prize, right?
Mm-hmm.
Here's another example. How many times have you seen folks, and we're talking about pediatrics here more than others, but they participate in some sort of travel sport that's their sport, like travel soccer or travel gymnastics or whatever, as well as their high school. So it's like, which one is more important to you? Is it, do you really want to participate in this or, this championship? We know you want to participate all the time, but you really need to shut down. You need to rehab, whatever. If we can get you back to 60, 70% for this, is that important? So kind of help them make that decision rather than just plowing right through. So I think that's a great point.
Yeah, I mean, we talk about all these timelines, and that's the hard part is we know there's timelines for a lot of recoveries that are just generalized for soft tissue things. But like you said, I think things have to be very individualized depending on the athlete, the part of the season. As you said, club sport versus high school sport, senior year, last game, there's a lot of things that play into it. And I like to try to make a lot of these decisions pretty individualized based upon all those things. And I think it's important to ask those people those questions because it could be very different depending on what they want or their expectations.
Listeners, please follow up next week for a continued discussion on when can I return to sports. I hope you can join us at one of our upcoming CME meetings. We have our musculoskeletal ultrasound workshop from February the 28th through March the 2nd in Charlotte this year. Look on PAOS.org for details.